slides up, and I just imagine a patient with cognitive impairment showing up there. Seems a bit interesting. But I'm like a proud father up here because I was involved in the training of all these three, and they're doing such a fantastic job. It's unbelievable. And all of them were within the time period, so I couldn't be more excited. So I'm going to give a quick historical case, and then we'll get on to questions. Bobby has questions that have come in virtually. If you want to ask a question, please go to the microphone as we go through. So this is my favorite neurologist slash neuropathologist. I'm Canadian. He was born in Canada in Waterloo, Ontario, not far from where actually I'm from, in 1913. His mother died when he was 11 years old, and he was one of, I think, 10 kids or so. She died in childbirth. He went to medical school in Toronto and then was a house staff in Quebec. And of course, this thing called World War II broke out. And as a lot of Canadians did at the time, volunteered for war service. He was in the Canadian Navy. There's a picture there. Anybody know who he is at this point? Who? Yes. So he enlisted in the Canadian Navy in 1940, and he was loaned to the British Navy, again, which was very common. He boarded the HMS Voltaire. You can see what a battle-tested ship this looks like, out of Halifax. And, you know, with all the defense mechanisms, it's hard to believe, but it was sunk by a German ship in 1941 called the Thor. Sadly, you know, over half of the individuals on the boat were deceased in the damage. He was in the water for multiple hours. It wasn't one of these things where half the crew was eaten by sharks, but he was bobbing around in the water for quite a while and then was rescued. But he was a prisoner of war from 1941 to 1944. And everybody I talk to now, their kids are doing gap years. This is not the kind of gap year that the kids are doing these days for 3 years. He was in Stalag XB in Germany. His wife was pregnant, and I'm not even sure he knew she was pregnant at the time. With the first child, she had gotten pregnant just when he was sent out. Then he was transferred to a different prisoner of war camp. And this really had a profound effect on his life as a physician and what happened with him in the camp. And physicians were really looked at not the same as general prisoners. They were sort of not looked at, they were fighters, so they involved them in care of patients and that type of thing. But it really fostered his attitude and behavior in life as it went through, and he really didn't have a lot of interest in material goods, money, or finances. Probably not that exciting for his wife later in that regard. But there's the camp. It's very, very exhilarating. Everybody's looking at peak of perfection and high performance. So post-war, he went to the Montreal Neurologic Institute and became interested in neurology. And he came in, very pivotably, he came in contact with Penfield, a neurosurgeon. And he was originally going to do metabolic stuff like Bobby discussed in diabetes, but his turning point was really a patient that he saw that had focal seizures. And they heard the hearing of beating drums, tom-tom drums, before they would have a seizure. And he was a deep thinker, and he started thinking about this, and he came to Penfield and he said, you know, I think there's a tumor in Herschel's gyrus. So Penfield took him to surgery, and he had a tumor in that location. So everybody thought this is someone we really need to pay attention to and really is outstanding in what he's doing. So he was offered an acting neurology position, and then he did a neuropathology. He's really more a neuropathologist than a neurologist in Boston, and really dedicated his lifetime. I put this in for Blake because he really defined so much in stroke, and he really said that we learn neurology stroke by stroke. And when I trained back in the day, and some of the people in my age vintage, we did a lot of brain cutting, which I don't think they do anymore, but we would go with the pathologist. They would slice the brain, and they would beat us up and go through all the anatomy and where's the lesion and what it would affect and those types of things. But Blake would like this because he wrote on the occlusion of the internal carotid artery. It was a 31-page paper, so just a heavyweight. And previous to this, it was thought that really everything in the brain was an MCA infarct. Blake talked a fair bit about, you know, embolic stuff from the neck. And he's really, Miller Fisher really was the first one that defined this. So it really brought in a whole new avenue. And a lot of the literature at the time was German, but one of the things he took advantage of when he was a prisoner of war for 3 years is he learned German. And that enabled him to read a lot of the literature at that time. So here's C. Miller Fisher. And I won't go through all of this, but he defined all the lacunar strokes. And he had the discussion about lipohyalinosis and all the mechanisms of action. You can see all of this stuff here that he did, but just stroke after stroke after stroke thing that he really defined. But he did so much more than stroke, and we won't go into that, but defined a lot of other types of things. He moved to MGH in the 50s and really spent 50 years there, really, almost. Created the first stroke service. He died at the age of 98 in 2012. So very sad. And I won't go through this for the sake of time, but he developed a lot of rules, and they published this after he died. But essentially it was really look at the patient as a person and really give it your best effort and really go to the bedside and really try to figure out what's going on. And don't just count on imaging, but really talk to your patients and examine your patients. And I think that we can all get a little too carried away with imaging as we go forward with that. But my favorite neurologist, neuropathologist. So there's a really nice book that's out there about his life that's well worth reading if you're interested in history. So thank you for that. So I'll ask the first question here, Blake, and I'll ask you a question. And you know, the thing that struck me when you were giving your discussion was, and I've always thought this on the stroke trials, is you guys are really good at doing clinical trials. But I'm concerned about what happens in the development of the clinical trials. And it seems like there's too many people standing in separate sandboxes, and you need to get in the same sandbox. Because the thing that struck me when you were going through it is that, boy, if we would have accounted for this, boy, if we would have looked at this factor, boy, if we would have done this. So just talk to me. I know it's more philosophical, but talk to me about stroke trials and what can we do. Maybe we need to ask the questions more up front, but tell me your thoughts about that, if there's a question in that.
Yeah, I think some of your points are valid, and what you see in a lot of the stroke trials is that there's a lot of work done on the same topic, and then a big push of literature is published, and it all pretty much says the same thing, which is nice that you have multiple different trials all showing something similar. And then out of that cohort of what they're looking at, maybe a new question will be asked, but I think it loses some practicality, and I think that you're right is that there's not differing views. Or I talked about how many trials do we need on antiplatelets versus warfarin. I mean, I don't know. How many trials do we need on blood pressure management and ICH? I think that some of these we have answers to. It's time to think about some alternative strategies. I don't know if we're as forward thinking. The other thing that you have to remember is that we do a lot of things in stroke based off of our cardiology colleagues. Don't tell any of them I said that out loud. But we're a good 10 years behind everything that they do in cardiology. And so a lot of what we do is trying to figure out if some of the cardiac literature can be expanded upon from a cerebrovascular standpoint. So I think that's why sometimes we're a little bit behind too.
So again, if you have a question, please come to the podium. Someone's got to crack the foil there. Bobby, why don't you ask one quick question from the virtual audience, because I see someone making their way. And
so this one's for Carrie. You had mentioned, at least briefly, I think with a question mark next to it, about neurofilament light chain. Is that something you use in your practice, or is it something we need to look forward to in the future?
That's an excellent question. So we have a lot of evidence right now that is pointing towards serum neurofilament light chain being a marker of breakdown of axons and disease, both at the macroinflammatory level and the progressive level. But the problem with using it is that we have to be very careful because it's not just specific to MS. We can see it if you bump your head. So especially for our patients who are aging, how are we going to use this as a marker and for what? It is a cheaper way to look at active inflammatory disease and potentially response to treatment. We are getting closer and closer to potentially using this in the clinic. There are many papers that have come out. Some good work through the consortium of MS centers have put together a white paper on how to use this in the clinic. Personally, I'm not using this just yet. I think that there are some issues with reference ranges, and how do we standardize this across patients, and if we don't have a baseline on that individual, because we get a lot of patients coming in who have had MS disease for years. Well, what does it mean? So I think we're getting closer to it, and as I'd mentioned before, we may be able to start using SNFL, serum neurofilament light chain, as a marker of disease activity and response to treatment. But I still think we need a little bit more work to try to settle out some of these nuances that can complicate the validity of the use in clinical practice.
Very good. Our brave soul at the microphone, please. Yeah, that's you.
Oh, wow. All right. So this is kind of a segue, I guess, to that question. It's a more general question about progression in MS. Let's say one is practicing in a state like, I don't know, Montana, where leaving the paved road, it could still take 35, 40 minutes to get to a residence, where people are at least 2 hours away from any major medical care. So the clinical trials and about progression, and they have OCT, and they have the expanded thing where you check 60 different functions of a person, and you're saying you're running. What would be considered probably the bare minimum evaluation of a patient when one is not in a major medical center, doesn't have residents or anybody doing this kind of stuff to do it for someone, has to all to be done by the physician? What would you consider to be the bare minimum to be able to follow a patient with MS and say, other than obvious relapse? So they're not relapsing, they seem to be okay, they say they're okay, they look okay. What's the bare minimum evaluation? I know I think an easy thing to do is the digit symbol and do that, and the time walk I think is pretty reasonable, although sometimes I'm not sure about what the changes in those mean. So what is needed to be done to say a patient is responding to therapy or not?
So I'm going to go to, and thank you so much, because this is actually a big question, because a lot of the times when we're talking about how we manage our patients, we're talking at this level, that assuming that we have all of these things available to us, MRIs and iPads that are able to do all of these really cool things when we are evaluating patient-reported outcomes and all of these different tools, access to OCT machines, access to visual evoked potential, so on and so forth. But really at the bare minimum, I would say really two things. Listen to your patient. Listen to what they are telling you. It is so vital. And two, a good neurologic examination. Watch your patient walk. If you can do a timed 25-foot walk and a 9-hole peg test, that would be great. The ways to do this is really cheap. With a timed 25-foot walk, all you need is a watch, or maybe an iPhone, or some sort of way to keep time. And then with the 9-hole peg test, I mean, they still have the cheapy plastic versions that are just a few dollars. And if there's a way to do a single digit modality test, I mean, we can print this off of the internet. It's freely available. We could use those clinical tools in addition to what the patient's telling us to see whether or not they're doing well in their therapy, both from a relapse and a progression standpoint. And I'm going to pay more attention to your comment on the progression standpoint, is really listen and watch the patient. We really don't need all of these additional modalities to get at the fundamentals of this. And then to your second part of the question, what is considered clinically meaningful when we're looking at timed 25-foot walk, 9-hole peg test, SDMT. So for timed 25-foot walk and 9-hole peg test, it's really a 20% worsening from the time before. That's considered clinically relevant. With SDMT, we used to say a score of a 4-point difference in their processing speed, but now we're actually looking at an 8-point difference as clinically meaningful. So really, you just need those tools.
Very good. I think Bobby has a virtual question for Blake.
Yep, a two-parter from two different people. One is there a specific level that you use on the platelet aggregation studies to determine resistance, or if it's low, then you want to consider it and consider switching? And then do you have any preferences in any specific circumstances for one DOAC over another?
One of the problems with how different systems test for the activity of antiplatelet agents is that none of this is validated. And so you really have to go based off of what your lab has internally validated. So for instance, what we use is, again, platelet aggregation. We look at ADP and arachidonic acid for patients that are on, any sort of P2Y12 and then aspirin respectively. And our cutoff numbers, normal platelet aggregation is somewhere north of 70 on our assays. And so less than 40 on our ADP and less than 20 on our arachidonic acid signifies that they are responding appropriately to antiplatelet therapy. But you just have to check with your own lab because every lab does it differently. Some places measure P2Y12 inhibition, and then again, some measure the metabolization of clopidogrel. So you just have to look internally. And then as far as the second question goes, it's really dependent on the patient and dependent on their clinical status. Do they have concomitant, comorbid coronary artery disease? Are these patients that need to be on low-dose rivaroxaban and an antiplatelet agent, like with a COMPASS trial? Have they failed some sort of antiplatelet agent before in the past? And then cost. I think cost is huge. And how long are you going to have the patients on that medication? So if I could put everybody on ticagrelor, I probably would, just because I know that that's going to be the most efficacious, but it has some long-term risks, especially in elderly patients. The bleeding risk is significantly higher. So I think that you can get away, especially if you're doing dual with clopidogrel and aspirin. Aspirin 81 is no different than aspirin 325. Many studies have shown that escalating your aspirin, unless you're showing that there's a platelet aggregation problem, doesn't do any good. So baby aspirin and clopidogrel is a good place to start. And then for high-risk patients or patients not responding, switching over to ticagrelor makes sense.
Thanks, Blake. So I have a question for Carrie while anybody's getting enough energy to walk up and ask another question. So my mother had MS. I'm always interested in what's going on in the MS field. And, just so you know, I wasn't sleeping when I was over here. I was actually paying attention to your slides. I was actually a bit surprised on one of the clinical trials, and I don't know if it's one that Ontaneda was doing, but the primary endpoint was brain volume. And you talked a lot today, and I never once heard the term brain volume. So I thought it was interesting that the primary outcome is something that is nothing that we're actually marking or is part of any of the stuff we're looking at. So, and I'm sure there's 1,000 secondary endpoints that are looking at, but can you just comment on that?
No, and thank you so much for bringing it up. I probably just, superficially went through it because I wanted to keep time. But you're referring to the Deliver MS trial, which is one of the two pragmatic prospective trials evaluating early high-efficacy therapy versus escalation approaches. And the main difference between the two trials is the primary endpoint. So the primary endpoint with Deliver MS, which the Cleveland Clinic is leading, is brain volume loss. While in Treat MS, the primary endpoint is a clinical endpoint, which is the EDSS. The reason why brain volume loss was chosen as a primary endpoint is because it has one of the strongest MRI radiologic predictors of disease progression further out. And one of the concerns was that if we were not able to get additional funding for a longer duration study, 3 years at the core study is not really long term. So being able to use a proven and validated radiographic marker for disease progression, that's why it was chosen. But fortunately, we've been very lucky. We've gotten funding. I sit on the study steering committee. We've been able to get funding to extend this out to 6 years, and we may be able to get additional funding to follow these patients prospectively even further out than that.
Okay, thank you. Susie.
Hi, this is for Carrie too. So similar to Dr. Stevens, I have 3 family members with MS. So I'm curious if there's any hereditary or genetic testing going on or advancements in that? I know when my father was diagnosed, they said, no, it's not genetic, but with 3 family members, it seems there could be something there.
No, thank you for that. And the easy answer for that is that, yes, there is an inheritable genetic factor that is involved with really all autoimmune diseases, specifically at the HLA-DRB chromosomal factor. We are not doing genetic testing as part of routine clinical practice, and in a large part because by the time the patients get to us, they've already manifested the disease in some way, whether it's this radiologically isolated syndrome where, I mean, it's too late. The disease has already manifested itself. It just hasn't manifested itself clinically. But with more and more information that we're getting, for example, from the trial that just came out a couple of years ago, looking at thousands of veterans who tested positive for Epstein-Barr virus and actually had risk of MS versus the opposite side where there was no risk of MS if they tested positive for if they tested negative for Epstein-Barr virus, that might actually be a trigger for people who have that genetic susceptibility. So if we are starting to see patients, and probably not, by the time they come see me, they probably already have the disease, but if they're going to see their GP, their PCP, there's a strong family history of MS, well, what can we do? Do we check an EBV VCA? And if so, and we start getting vaccinations, do we start vaccinating them when there's a strong family history, there's an increased propensity for them to develop the disease? So a lot more information to come on that. But yes, there are, I have many patients who come in and there's a line of family members with MS. And then I have patients coming in where they're the only one with any autoimmune disease in their family. So more to come on that. But thank you for the question.
Thank you. Bobby, I think, has a question, then we'll get to the audience question.
Yep, so this is sort of directed at me. So the question is, if you see someone with an obvious cause of neuropathy like diabetes or alcohol abuse, do you even bother checking any other tests? And so in patients who have chronic neuropathy, I kind of alluded to this in my last case. If you have an obvious cause, I think the only obligation that you really have, number one, is to screen the other labs, so making sure that they don't have a B12 deficiency and an immunofixation. Again, from a cost-benefit standpoint, those are the highest yield, so just making sure that those are checked is something that I would do in everybody. But otherwise, no, I think if you see somebody who comes in, the onset of their clinical neuropathy fits with their disease course of something like diabetes, their exam is exactly what you would expect, and they manage their A1C and they move forward as you would clinically expect them to, then I think you're fine managing it as such. I don't think you have to do any other testing. At the same time, again, I will go through with every patient their family history, their cardiac risk factors of things like amyloid. I will go through their GI history just to make sure they haven't had bowel resections or gastric bypass surgeries, things of this nature. And if they have other risk factors, I will do additional targeted testing, because I always have said if you can diagnose other contributors via a blood test, it's a fairly inexpensive way to find that. If you have something in the history that would make you believe that that's a possibility, I think it's reasonable to check those.
Okay, thank you. Yes.
For Dr. Is it Mark? Sorry, Marquardt. Sorry,
You did very well.
That was pretty good.
So, in your clinical case about the porphyria patient that had the basically acutely rapidly progressing weakness and sensory loss, that obviously in the setting that somebody would be, that patient were to present to the ER, not having, obviously, like before having done any of the workup, there would be obviously a very high suspicion of GBS until you prove otherwise. And my question is, if you're being consulted on seeing that patient, do you recommend kind of, as the workup is still being done and they haven't had like the positive porphyria testing, that you would have them, let's say, IMU status, have them do like pulmonary functions, like NIFs and vital capacities every 2 to 4 hours? Like, would you already be kind of recommending that those sorts of admission kind of orders for the primary team before the workup is completed?
Yeah, I think I understand kind of the gist of the question is how quickly do you recommend some of these esoteric tests and things that are very uncommon? I think anybody who comes in with an acute neuropathy into the ER that you're consulted on is going to be managed as GBS until proven otherwise. That's kind of the way I would think about it. And so I would certainly, if somebody comes in with that, you're going to be consulted as a neurologist, and whether they get admitted to a neurological service, if you have that available, or if they get admitted to a medicine service, yes, I would be telling people this, especially if they have a significant neuropathy or a significant progression, that this is somebody who may end up needing ICU level care if they don't already, especially if it ends up being GBS. If they've progressed so rapidly over 3 to 5 days, that's somebody who could continue to go downhill very quickly. And so, yes, I would be making sure they were monitoring their autonomic function, their respiratory function very, very carefully. And then as you go through the diagnostic process, however quickly that would happen, again, if this is somebody coming in on a Friday night, even at our institution, we're not going to get an EMG until Monday, right? So that's 3 days that we have to manage this patient without an EMG. And that's where I think if you have the ability to do a lumbar puncture with relative haste, get an MRI of their spine to really kind of try and at least get some initial data. If you start to see signs that are consistent with GBS, then I think you manage it as such. But if you start to see your MRI, your lumbar puncture, whatever data you have available to you is coming back and their protein's not significantly elevated, their MRI doesn't have any unusual features of enhancement, then I think that's when you would need to go back to the drawing board and say, maybe we're dealing with something else. And that's when I think if you have the ability to do electrodiagnostics, they significantly add value, because if all you see is axonal change, that's when you start thinking down these other pathways. Do they have acute vitamin deficiencies? Do they have porphyria? The kind of these more rare diagnoses. But I think in general, everybody's going to be managed as GBS until you prove that they don't have GBS.
Okay.
And similarly, if it was a Friday and we can't get any of the tests done, if your clinical suspicion is an acute neuropathy, they don't have reflexes, most of us would give that person treatment. Right. You're not going to wait until Monday to try and get any of these things, your ducks lined up. You would go ahead and treat them if that was your clinical suspicion.
So like in that situation, it would be okay to go ahead and set up for IVIG or Plex, depending on what the syndrome.
Yeah, I think so.
Okay,
Yeah.
Thank you.
Yeah, and I can't overemphasize what Bobby said there. All of these people need to be on telemetry. Whether or not they need to be in an ICU, we will usually move them to a step-down unit, but you do not want them in the furthest bed, non-monitored from the nursing unit, because they can go south quick as it goes through. Yes?
How would you differentiate between GBS, chronic CIDP due to GBS, versus alcoholic neuropathy in a patient who has history of chronic alcoholism?
You mean in the acute setting?
Yes.
So the people who come in with acute nutritional neuropathies from things like alcoholism, they have recurrent vomiting, they have multiple nutritional deficiencies because of that, they're going to present very similarly to a GBS patient typically. And so they're going to have this GI prodrome of nausea, vomiting, and things like that, followed by acute onset neuropathy. If you have access to early electrodiagnostics, that's very helpful. But if you don't, that's where I was saying, I think you're going to manage that patient initially as Guillain-Barré, and you're going to admit them to the hospital and manage them as such. And then as you start to do whatever workup is available to you, if the data starts pointing away from demyelination, so your MRI comes back with no enhancement, your lumbar puncture has no protein elevation, that's when I think you should be thinking, could this be one of the other issues? And so if you have somebody who comes in with a lot of vomiting, something that we will do is we will send things like B1, folate, B12, copper. We will send nutritional labs in those people. We'll send an ESR and a CRP to see, could this be an acute vasculitic problem? Again, all of these labs have issues, especially inflammatory ones, because they can be falsely elevated in a variety of situations, but at least sending some of those labs to get an idea of which direction you may be headed can be valuable. But ultimately, when you're examining them, they can look identical.
And what would be the treatment other than thiamine and folic acid for chronic, for alcoholic neuropathy? Is there anything else?
So in the acute setting, there's not a whole lot you can do other than vitamin replacement if you find vitamin deficiencies. So we would put all of them on high-dose thiamine, same as you would do for a Wernicke's patient. We would replace any other vitamin deficiencies that we could. A nutrition consult to make sure that you are refeeding them appropriately to monitor for refeeding syndrome. That's something we'll pass on to our ICUs, for example, if we have a suspicion that they've had a very significant GI prodrome. And then very, very, very aggressive physical therapy when they leave the hospital. That's about all you can do. And obviously alcohol cessation.
So I think we're up against the time. We probably have time for one more question, so why don't you go ahead? Well, we got two. Let's do these two questions, and we'll be done.
Yeah, this question's for Dr. Hirsch. I recently had a patient who was diagnosed with AIDS. CD4 count was pretty low, but also diagnosed with, newly diagnosed with MS, including lesions in the spinal cord. So that obviously represents a management dilemma. So you want to aggressively treat their MS with high-powered immunomodulatory agents, but by doing that, you could potentially increase their viral load and potentially lower their CD4 count. So how do you reconcile those two concomitant disease states?
Yeah, sure. And I heard AIDS in the first part, AIDS and MS. Yeah, so as you had mentioned, we have to be very careful about, weighing the balances between, being as aggressive as we can about the MS, but we also want to be careful because some of our immune reconstitution therapies, we're going to be decreasing some of their T cell counts. We have to be very careful. I would say that, one option, it's not the most highly efficacious option, but you could try a fumarate. We tend to see not so many issues, especially with the patient being younger with lymphocytopenia, although that does need to be monitored very carefully. I would probably say, usually for my patients who are otherwise healthy, I'm monitoring every 6 months. For a patient who we're very concerned about immunodeficiency because of another disease state, we might want to do it every 3 months instead. If that is not an option, or they break through on a fumarate, another potential is a B-cell depleting therapy because mechanistically, yes, we're going to be driving down B cells, maybe leaving those T cells alone, but it really depends on what their viral load is at the beginning and then what particular treatment that they are and how stable they are on that therapy. So it really kind of depends on how worried you are about the patient in terms of the MS and their HIV/AIDS. So I'd probably say if you want to be on the more conservative side, you may want to consider a fumarate, which is still a moderately efficacious therapy. And then if you have to escalate, you can go ahead and do so.
And our last question of the morning.
Yes, so I have a question for Dr. Hirsch. So I have a patient who's 38 years old, diagnosed with definite MS 7 years ago, presented with ataxia, optic neuritis, and left hemisensory deficit, treated with steroids. I had recommended ocrelizumab at that point for the patient, but patient opted for glatiramer acetate. Within a year's time, patient had 2 relapses, finally came back and agreed to start ocrelizumab. Now, he's been on it for over 6 years, or about 6 years. Gamma globulins are fine. He's not had any infections which were concerning. He's telling me, can I stop it? And we repeated MRI, and in fact, some of the T2 lesions that were seen, the demyelinating lesions, have actually decreased in size. And the MRI looks really fabulous, and I don't want to take him off this, but he wants to come off this, so what would you suggest?
How old is your patient?
38 now.
So 38 years old is young to be talking about DMT discontinuation. When we're talking about DMT discontinuation, mainly we're considering this in older patients. Some folks are defining older as older than 55. Other folks are defining it as older than 60, 65. But 38 for me is too young to take them off of DMT completely. It really kind of depends on what the reason is for the individual wanting to come off of treatment. If it's just because, hey, I want to see what happens, then You may want to have some of that shared decision-making conversation with the individual. If they're tolerating it well, the safety's okay, they're doing really well, of having another, here's the truth data on if you discontinue completely this, your disease may come back. Fortunately, we're not going to run into the issue of rebound disease as we would with either an early generation S1P or with natalizumab. But if the patient is really set on, I don't want to be on this anymore, it's going to be shared decision-making on an alternative treatment approach, whether it's de-escalation or doing a lateral switch. But I would be very wary about taking a patient off of DMT completely at 38, where there's still some macroinflammatory disease risk.
Thank you.
All right, so thank you very much, everybody. We will start promptly at 10 after 1, and we'll be doing epilepsy. Thank you very much. Make sure you visit with the vendors. If you need the ABPN, make sure you sign up. Thank you. Late. One question I didn't get to ask, because again, I pay attention to the slide.